At RSNA 2023, experience the future of medical imaging when the radiology community comes together as we help you discover how to lead through change. Immerse yourself in the latest technological developments, see imaging innovations in action, sharpen your skills with high impact learning, and connect with radiology colleagues from around the world. Join us November 26th through the 30th for the biggest week in radiology, either in person, virtually, or both. Register now for RSNA 2023 at rsna.org/register. Hello and welcome to the RSNA Radiographic Podcast. I am Gagandeep Choudhary, a nuclear and neuroradiologist from the Oregon Health and Science University, Portland, Oregon. Today we will be talking about multimodality imaging of dementia, clinical importance and role of integrated anatomic and molecular imaging, a radiographics article by Dr. Kunal Patel, Dr. David Weimer, Dr. Vinay Bhatia, Dr. Ranjan Dwara, and Dr. Chetan Rajadiksha from the Department of Radiology, Mount Sinai Medical Center, Miami Beach, Florida. This article focuses on the pathophysiology and imaging findings of some of the major neurodegenerative processes. It discusses how we can integrate both anatomical structural imaging and physiological molecular imaging in the diagnostic workup of these neurodegenerative disorders. Neurodegenerative disorders are a devastating group of conditions that can be challenging to diagnose accurately, while managing these disorders can be difficult due to limited treatment options, and early and correct diagnosis can aid in symptom management and coping with the later stages of these diseases. Neuroimaging techniques, both structural and molecular, have advanced to the point where these diseases can now be identified relatively early with high accuracy. Traditionally, the role of structural neuroimaging in dementia has been to exclude other possible causes that results in cognitive impairment, such as intraocular hemorrhage or space occupying lesions. However, with widespread availability and recent advances, its role in neurodegenerative disorders has expanded. Knowledge of relevant anatomical structures is also a prerequisite for performing structural assessment in dementia. Often the initial step is to assess global cerebral and cerebellar volume loss, followed by a more in-depth assessment of regional and lobar pattern of volume loss. Many brain regions are directly involved in common neurodegenerative disorders and are vital for interpreting anatomical imaging. For example, the precuneus, which is the medial part of the parietal lobe, and the mesial temporal lobe are involved in Alzheimer's disease. In routine clinical practice, volume assessment is usually qualitative, leading to ambiguity and inter-observer variability. There are multiple semi-quantitative visual rating systems and specialized software programs that can provide volumetric analysis. When performing a dementia MRI, it is important to obtain a high spatial resolution volumetric T1 weighted sequence with multiplanar reformations, as well as a T2 weighted coronal sequence. The T2 weighted coronal sequence should be performed perpendicular to the long axis of the hippocampus for evaluation of mesial temporal lobe. There are multiple nuclear medicine imaging techniques and agents for the evaluation of neurodegenerative disorders, including PET with fluorine 18 fluorodeoxyglucose and beta amyloid, as well as SPECT with iodine 123 ioflupine, commonly referred to as STAT scan. One of the most commonly used PET radiopharmaceutical is fluorine 18 fluorodeoxyglucose, better known as FDG, which is a radioactive glucose analog. It is taken up by metabolically active cells, creating metabolic map that is primarily used in oncological PET imaging. Moreover, as the brain is almost entirely glucose dependent and metabolically active, FDG allows the visualization of functioning cerebellar cortex. In neurodegenerative diseases, the underlying pathophysiology causes damage to cerebral tissue and alter their normal metabolism, which can be observed on an FDG PET scan. Although the lack of functioning is non-specific, it can reveal the distribution pattern of metabolic derangement, providing specificity in the differentiation of neurodegenerative disease processes. Apart from minor differences, the recommended imaging protocol with FDG is quite similar to that of the oncological PET. Now we have multiple approved radiopharmaceuticals that allow visualization of abnormal amyloid plaques in the cerebral cortex. All the traces have a similar mechanism and bind to the beta amyloid plaques in the cerebral cortex. Because of their lipophilic nature, these tracers normally bind to the myelin of the white matter tracts. Typically, negative scan show more radioactivity in the white matter than in the gray matter, creating a clear gray-white contrast, which indicates sparse to no neurotic amyloid plaques. On the other hand, a positive scan will display increased cortical binding of the tracer with reduced or absent gray-white matter contrast in multiple regions, indicating moderate to frequent amyloid neurotic plaques. In patients with atrophy with thinned cortical ribbon, interpreting amyloid scans may be difficult. In such cases, fusion with concurrent or recent structural imaging is often useful to better clarify the relationship between gray matter anatomy and tracer activity. The nigrostriatal pathway is a major dopaminergic pathway in the brain that connects the substantia nigra in the midbrain with the corpus striatum, which includes the caudate nucleus and putamen located in the forebrain. The loss of dopamine neurons in the nigrostriatal pathway is one of the primary pathological features of Parkinson's disease. Iron 123 ioflupine, commercially referred to as DAT scan, bind to the dopamine transporters and thus allow visualization of active synapses in the corpus striatum. This agent has demonstrated efficacy in detecting degeneration of dopaminergic nigrostriatal pathway, facilitating the differentiation of patients with essential tremors from those with Parkinsonian syndrome. Dopamine transporter concentrations are lower in presynaptic Parkinsonian syndromes, including Parkinson's disease, multisystem atrophy, and progressive supranuclear palsy. They are also lower in dementia with Lewy bodies. In contrast, dopamine transporter concentrations are generally normal in Parkinsonism without presynaptic dopaminergic loss, such as essential tremors, drug-induced Parkinsonism, and psychogenic Parkinsonism. Additionally, in contrast to dementia with Lewy body, dopamine transporter concentration are usually normal in Alzheimer's disease. One of the newest imaging agents available uses the binding of tau protein. These agents bind to intra and extracellular neurofibrillary tangles. Although many are currently in development, fluorine 18 fluorotisopir has been approved by the FDA. These agents have good target to background ratios with healthy patients exhibiting minimal uptake. The accumulation of radiotracer should correspond to pathological areas of abnormal tau accumulation, such as within the hippocampal body and precuneus in cases of Alzheimer's disease. Due to good target to background ratio, even low level uptake in the mesial temporal lobes and entorhinal cortex can represent early pathological changes of Alzheimer's disease. Chronic traumatic encephalopathy has also been shown to demonstrate diffuse tau tracer uptake along the gray-white junction related to underlying causes of chronic injury and shear forces at these locations. Neurodegenerative disorders represents a heterogeneous group of neurological conditions characterized by the progressive loss of neurons. While the precise mechanism underlying these diseases remain largely unknown, they can be broadly characterized based on shared histopathological features. Three key categories relevant to imaging includes tauopathies, beta amyloid accumulation, and alpha-synucleinopathies. Tauopathies involve the aggregation of misfolded tau protein leading to the formation of neurofibrillary tangles. Conditions falling within this group includes frontotemporal lobar degeneration, corticobasal degeneration, and progressive supranuclear palsy. Alzheimer's disease also exhibits tau aggregates, but is considered a secondary tauopathy given the equal or greater representation of beta amyloid accumulation in the disease process. These can be imaged using tau PET agents. Beta amyloid accumulation is one of the primary hallmarks of Alzheimer's disease, which can be detected by amyloid-specific PET agents. Alpha-synucleinopathies are characterized by abnormal accumulation of alpha-synuclein, forming Lewy body inclusions. Parkinson's disease, dementia with Lewy bodies, and multisystem atrophy falls within this subgroup. Clinically, these conditions present with Parkinsonian symptoms with damage to the basal ganglia and typically have abnormal ioflupine SPECT scan. Alzheimer's disease is by far the most common neurodegenerative disease, accounting for the majority of dementia patients. It affects nearly 5% of all individuals 65 years or older. Histopathologically, this disease is characterized by the accumulation of beta amyloid plaques and misfolded tau protein neurofibrillary tangles. Clinically, Alzheimer's disease begins as mild cognitive impairment, which slowly progresses to outright dementia. On structural imaging, the earliest atrophic changes are depicted in the mesial temporal lobe, followed by the limbic system and hippocampus, eventually involving the cortex, particularly the precuneus and lateral temporal lobes. On FDG PET, the typical pattern of hypometabolism involves the parieto-temporal regions, precuneus and posterior cingulate gyrus, with sparing of sensory-motor strip and occipital regions. This pattern generally corresponds to atrophic changes depicted on structural imaging. Precuneus and posterior cingulate are among the first to become abnormal. In severe advanced cases, you can see involvement of frontal lobes too. Posterior fossa structures and deep gray matter nuclei are spared. On amyloid PET scan, abnormal cortical uptake corresponding to the beta amyloid accumulation is seen. Classic uptake is usually symmetric and diffuse throughout the cortical gray matter with sparing of the cerebellum, which is used as an internal control. Although amyloid deposition can be seen in older people with normal cognition, negative amyloid uptake has a high negative predictive value for Alzheimer's disease. On tau imaging, the uptake distribution follows the pattern described in the Braak staging system, starting with the mesial temporal lobes, then the limbic system, the hippocampus, and eventually the neocortical areas. Dementia with Lewy bodies is the second most common primary dementic neurodegenerative disorder after Alzheimer's disease. Estimates predicts that 10 to 25% of all dementia cases are related to dementia with Lewy bodies. However, it is likely underdiagnosed due to a general lack of awareness and misdiagnosis as traditional Alzheimer's disease. Histopathologically, there is an aggregation of Lewy bodies similar to what occurs in Parkinson's disease. Clinically, dementia with Lewy bodies is characterized by progressive cognitive decline accompanied by Parkinsonian and visual symptoms, often including visual hallucinations. The structural imaging findings are less conspicuous and nonspecific compared to Alzheimer's disease and frontotemporal lobar degeneration. Relative preservation of medial temporal lobes and less severe atrophy of the hippocampus can be observed compared to those in Alzheimer's disease. On FDG PET scan, the hypometabolism pattern is quite similar to that of Alzheimer's disease. However, relative preservation of posterior cingulate cortex results in so-called cingulate island sign, along with involvement of the occipital lobes. These features are helpful in differentiating it from typical Alzheimer's disease. Due to the degeneration of nigrostriatal dopaminergic pathway, the iodine 123 ioflupine scan is often abnormal in dementia with Lewy bodies. Unfortunately, beta amyloid imaging may not adequately differentiate dementia with Lewy bodies from Alzheimer's disease, as many cases of dementia with Lewy bodies may exhibit significant abnormal beta amyloid accumulation. Frontotemporal lobar degeneration is a term applied to a number of similar tauopathies that results in neuronal destruction in the frontal and temporal lobes. On histopathology, these diseases demonstrate the accumulation of abnormal tau proteins in the affected areas. The clinical presentation is divided into two main groups: behavioral variant frontotemporal lobar dementia and primary progressive aphasia presenting with language issues. On structural imaging, all the subtypes show predominant frontotemporal atrophy, with the severely affected regions displaying knife-like gyri due to the marked loss of brain volume. Relative sparing of the parietal and occipital lobes can be observed. On FDG PET, the typical pattern of hypometabolism involves the frontal and temporal lobes. Classically, sparing of the precuneus and occipital lobes is seen, aiding in the differentiation of frontotemporal lobar degeneration from Alzheimer's disease and dementia with Lewy bodies. Beta amyloid PET can be used to differentiate between Alzheimer's disease and frontotemporal lobar degeneration, as amyloid deposition is not a part of frontotemporal lobar degeneration spectrum. Lastly, vascular dementia, although not truly a primary neurodegenerative disease, is common and important to consider in the differential diagnosis for patients with neurocognitive impairment. It is the second most common cause of clinical dementia after Alzheimer's disease. Vascular brain changes often coexist with other primary neurodegenerative diseases. On structural imaging, typical findings include vascular insult such as encephalomalacia due to multiple vascular territory infarcts, white matter changes, and secondary signs of volume loss with enlargement of ipsilateral sulci and lateral ventricles. FDG PET will show areas of hypometabolism that correlates with abnormal areas seen on structural imaging. At the end of the article, you will find a very well-structured flow chart outlining the imaging workup of a patient with suspected dementia. The initial step should involve performing a structural MRI. This allows for identification of any alternative treatable cause before conducting any additional workup. If the diagnosis remains unclear, a review of the clinical history should be conducted to identify any Parkinsonian symptoms. In the presence of Parkinsonian symptoms, obtain iodine 123 ioflupine DAT scan SPECT. If the DAT scan results are negative or if the Parkinson's symptoms are absent, an FDG PET scan should be conducted. Further troubleshooting may involve considering amyloid or tau imaging to identify patterns that suggest an Alzheimer's disease diagnosis. If the distribution FDG PET indicates dementia with Lewy bodies, an examination with eye of lupin DAT scan can be considered. The article also contains multiple excellent imaging case examples and tables, which I highly recommend the audience to review. I hope that you found this discussion on multimodality imaging of dementia, clinical importance, and role of integrated anatomic and molecular imaging radiographics article useful. Thanks for joining this RSNA radiographic podcast.